Hello, everyone. My name is Amanda Watson. This is my Module 1 assessment for NM 702. I'm answering the question, what memories do you want your clients to have of the care that you provide? What things will you incorporate into the care you provide as a midwife WHNP to ensure these memories are made? So I wanted to bring us back to the midwife relationship model that was shared with us in Module 1 lecture notes. I really enjoy this model because to me it symbolizes a living symbiotic relationship between the midwife and the mother, and it reminds me of cell division. And it reminds me that a mother is born from this experience along with a child, and a family and a father, and that we have a huge responsibility and are sharing in a very sacred event by being a part of this relationship over time. So how do we leave that lasting impression? The Akhil Swaran article mentioned that the healthcare provider is the most powerful determinant of birth outcomes. And this leaves a lot of responsibility on us as providers in the kind of care that we give to the mothers that come to us, and a reminder that we are making mothers, as Rotham said, that we're birthing mothers, strong, capable mothers that are shaped by this birth experience. Not only should those mothers trust us, but we should also be instilling in them an inner trust where they learn to trust themselves. And this goes back to authoritative knowledge and transferring that authoritative knowledge back to the mother, so that it's not that they are looking to us to find that authoritative knowledge, but that we are turning that back to them. And really making this women-centered care where we're not just following a one-size-fits-all package that is driving our interaction with them, but that we're really listening, using our assessment skills to really hone in on what is really needed for this individual, and how can we cater out that prenatal visit and all of the care that we give them to really speak to that individual person. And that does, also tie in the cultural competence, that, there may be different expectations. There may be different experiences that this woman is coming from. Going back to the relationship model, the midwife relationship model, not only is the midwife surrounded by her environment and her practice, but she's also, the mother herself is surrounded by an environment. And maybe that is a culture of fear around childbirth. Maybe that is media. There's differences between a birth culture in Oregon versus a birth culture in Pennsylvania, as I found out myself. So not only does somebody's ethnicity determine this culture, but also just what they are exposed to and what gets defined as normal in their environment that we have to discover and we have to speak to. So in that being said, also going on to some of the barriers that may make implementing the midwifery model of care difficult in our relationships with women is the over-reliance on technology, as was discussed in several of the articles, and that, midwifery is a high-touch profession and a low-technology profession. I want my patients to remember my touch. I want to remember that I felt their baby inside of their belly. It's we have this reliance on ultrasounds, for example, that don't have evidence to back up that, they really have any significance on outcomes. So, how do we operate a midwifery model of care in this high technology environment and still gain the respect and camaraderie of our physician counterparts when we may focus more on normalcy instead of risk, and try to implement that through hands-on techniques instead of an over reliance on technology. The Rotham article talks about the routine actions of care providers taking away experiences from women. So, Pitocin taking away the ability of the baby to take care of their mother by suckling, and that creating a woman's organic Pitocin or oxytocin release. The language that we use, the discovery of the pregnancy,